I want to welcome everybody. My name is Lynn Gallagher Ford. I'm the Senior Director here at the Fold Institute for Evidence-Based Practice in Nursing and Healthcare. I wanted to acknowledge the groups of people that have worked very diligently over the last couple of weeks to bring this information forward to you. And I also want to thank our support team, obviously Bindu, who is always the ultimate support. And some other, just the full team in general. So I'm not going to spend too much time saying hello. I wanted to give as much time to our presenters as possible. Today we're going to be sharing with you two topics, which is the first of which is early proning. And there's a big group of folks that have been working on that. And Cindy Zellefrow, Dr. Cindy Zellefrow and Dr. Cindy Beckett are going to speak on that team's behalf. And then the second topic we're going to be talking to you about is effective communication with mechanically ventilated patients. And our esteemed colleague from the College of Nursing, Dr. Mary Beth Happ, who is a well-established expert in this field, is going to be leading that discussion and sharing lots of great resources with you. So there'll be a lot packed into the webinar. There's also additional resources that we'll be sharing with you as a follow-up. And I'm going to turn it over. We're going to try and keep it under an hour so we have time for your questions. So I'm going to be quiet now and turn this over to my colleague. I believe Cindy Zellefrow is first in the queue. So thank you everybody, and stay safe out there. We appreciate everything you're doing in on the front lines and the second lines and third lines. And we're here for you. Whatever we can do to support you and help you, please reach out to us at the Fold. And we're sending all our positive safety energy to you. Okay, Cindy, take it away.
All right, thanks a million, Lynn, and welcome everybody. We're so glad that you were able to join us today. Today, Cindy Beckett and I are humbled, honored, and proud to bring forth to the information on early proning in COVID-19 patients. As we do so, this work was not ours alone. It was certainly a team effort. And so just very quickly, I wanted to give you acknowledge the names of those who worked on this. So Kim Ichrist. Kim is an adult gero acute care NP in the neurocritical care at the James Cancer Institute, which is part of OSUMC. She is also one of our DNP students here at Ohio State. Sheena Palmer, a family nurse practitioner in adolescent health at Nationwide Children's Hospital and another of our DNP students. Laura Weigel Moore, a pediatric ICU nurse at Nationwide Children's Hospital, one of our graduate assistant at the Fold Institute and another of our DNP students. Christa Zellefrow, a bedside nurse in the surgical ICU at OSU Wexner Medical Center, and then of course Cindy and I. So let's go ahead, Bindu, and next slide, please. It seems hard to believe now that it's been 7 weeks since COVID has really kind of put a whole new spin on existence for us. And so wanted to start out by just taking a quick check of the numbers. So as of 4/20, again, COVID truly is a worldwide global pandemic with more than 2 million cases and over 155,000 deaths across the globe. In the United States, as of 4/20, we sat at 792,938 cases and 39,000 plus deaths. Next slide, please. The challenge with COVID is that many of its symptoms are that often mimic many upper respiratory viruses and influenza. An international group of experts from the Cochrane Collaborative came together and did a scoping review of all of the literature around COVID to look at symptomatology, diagnostics, etc. And as you can see, here are the list of COVID symptoms according to their scoping review. One of the and the radiographic diagnosis of COVID. One of the unique things about COVID is that on chest CAT scan, it's showing that there are some unique ground glass-like opacities in the lungs, which ends up causing symptomatology that really kind of mirrors or mimics acute respiratory distress syndrome, or ARDS. So next slide, please, Bindu. And let's take a quick look at ARDS. So acute respiratory distress syndrome is really defined by the Berlin definition, which rose out of the European Society of Intensive Care Medicine's panel of experts that was endorsed by the American Thoracic Society and the Society of Critical Care Medicine in 2011. As you can see, the Berlin definition of ARDS really looks at the timing of the onset of symptoms in characteristics of chest imaging, the origin of edema in the lungs, and oxygenation. Of note, at the very bottom of the slide, ARDS is differentiated into 3 different categories: mild, moderate, and severe. And the lower the pressures, the more severe ARDS is. Next slide, please, Bindu. So proning has been part of caring for ARDS and has been studied in severe patients with severe ARDS who are mechanically ventilated for over 50 years now. But early proning has really become the talk of the town when it comes to COVID. As you can see, literally these headlines were just in the last week and a half, where CNN, USA Today, the New Yorker, etc., are all talking about early proning in patients with COVID. So next slide, please, Bindu. So let's take a look at the definitions of proning so we're all talking about the same thing. So according to Tabor's medical dictionary, proning is really placing a patient, especially one with respiratory failure due to ARDS, face down in that prone position. In the literature, talking about early proning, or also referred to as self-proning or awake proning, which is where non-mechanically ventilated patients are, again, put in that position where they're lying on their bellies rather than on their backs in the supine position. With early proning, self-proning, or awake proning, one of the unique characteristics is these patients are still oftentimes able to participate in the proning, and it's implemented as soon as a potential diagnosis is made. Next. Go ahead, Bindu. Thank you. What's nice, what's intriguing about the physiology of proning is that it really changes the dynamics of how the organs and structures lay within the chest cavity, giving us the opportunity to increase airflow, allowing the compressed alveoli to open up and improve fluid drainage out of those dorsal lobes, increasing perfusion to the lungs as well, which ends up causing an increase and improvement in oxygenation. In the image to the right, you can see the difference between, again, fluid drainage, compression of the alveoli, and blood flow to structures within the lungs in the supine versus the prone position. Next slide, please. So early proning was first implemented in Jiangsu, China, the province in China, where they had outrageously better outcomes than any of the other provinces within China. In fact, as of March 7th, they had 631 confirmed cases of COVID, 610 of which cases led to people being discharged from the hospital. So a cure rate of 96.67%, which far exceeded the national averages. But what was different in Zhejiang province is that they established a criteria to identify COVID on the very, very early side of things. Next slide, please, Bindu. And then implemented a 3-pronged approach to navigating and to treating COVID. First, non-invasive ventilation, so BiPAP, or using high flow nasal cannula, combined with restrictive fluid resuscitation and awake proning condition. And that's what they really feel, it was a combination of those 3 things that really made a difference in their survival rates. Next slide, please. So our team took to the literature and did a robust search. As you can see, we looked at CINAHL, PubMed, Medline, Medline Plus, Scopus, et cetera, et cetera. We also did a grade literature search and title search using keywords, mesh terms, subject headings, parentheses, truncation, and quotation marks, and the Boolean operators and or. In total, we ended up identifying 98 articles where abstracts were reviewed, and at the end of the day, we landed on 7 keepers that directly addressed awake or early proning, and an additional 13 articles that provided background information, including nursing and clinician intervention. Go ahead. As you can see from our level of evidence table, we had a nice distribution across multiple levels, including a systematic review, 3 cohort studies, a descriptive study, and 2 expert opinions. Next slide, please. And the evidence was clear. As you can see from the green arrows, proning, early proning really made a big difference in all kinds of ways. But of particular interest is the 3rd line down, where multiple articles addressed or identified an improvement in PaO2. In the middle of the table, you'll see the line that's where many articles identified a need, the decreased need for mechanical ventilation. And at the bottom of the table, the improved PF ratios, which are part of the diagnosis and the categorization of ARDS. Next, please. So at this point, I'm going to go ahead and turn things over to Cindy Beckett, who's going to take it from here.
Very good. Thank you, Cindy. So as we began to look at the synthesis, there was so much information on early proning, and we want to let you know that while you probably can't see the details in the synthesis table, we will be able to make those available to you, and I'll talk about that later in the presentation. But as we start thinking about indications, next slide, Bindu. So as you look at your patients, they've been admitted to the hospital, they are beginning to have serious complications. In order to consider this early proning, first look at their respiratory rate. Is it greater than 30? Heart rate greater than 120? SpO2 less than 93% consistently. FiO2 greater or equal to 0.06. The PaO2, FiO2 less than 300. So again, looking at those Berlin criteria. So if they have mild to moderate ARDS per criteria, they're definitely candidates for proning. And alveolar collapse that's been noted on radiographic images. Next slide, please. So as you notice, this is so difficult to see. We're going to spend a little bit of time discussing contraindications. So next slide. So first, when you're trying to determine which patients are appropriate for proning, things to consider are first abdominal. Have they had any recent abdominal surgeries or wounds? Do they have increased abdominal pressure? Do they have ischemia? Do they have an excessively large abdomen? And are they pregnant? And there are now some studies because of COVID in the pregnant population that they are proning gravid uteruses with pillows and even in using inner tubes. Cardiac, have they had a recent pacemaker placed? Do they have hemodynamic instability? Do they have left-sided heart failure, or do they have noted arrhythmias? Those would be considerations not to prone. Bleeding, have they had any acute bleeding episodes? Massive hemoptysis, have they had alveolar hemorrhages? So anything that would make it more difficult for breathing anyway would be a contraindication. Neuro areas would be any type of injury to the head, spine injuries or precautions, also any type of seizures or increased intracranial pressure would be a problem. In traumas, these could be burns, this could be injuries to the abdomen or the body, it could be unstable fractures, specifically in the pelvis, in the face, facial surgeries, kyphoscoliosis, and rheumatoid arthritis. A lot of different conditions. And these, again, are in your synthesis tables that you'll be able to see later. Also, increased intraocular pressure or ocular surgeries. In that face-down position, it's going to put much more pressure on the face and the eyes. Drainage tubes. We have to think about these if we've got drainage tubes that could be easily dislodged, like chest tubes that have maybe an anterior leak, thoracic or abdominal tubing. Tracheal surgery or sternotomies are contraindicated. People with profound asthma, so moderate to severe asthma would be a contraindication. And then high dependency airways and vascular access patients. Also, you want to consider the weight and the height of the patient. If they're greater than 135 kilos or less than 45 kilograms, these would be patients that would be contraindicated, and if they're greater than 195 centimeters tall. So next slide, please. So as we begin to look at clinical considerations, these are the things that we want to make sure that we are monitoring regardless of our discipline. So next slide. So as you're thinking of the positioning, there were two primary positions noted. First was the swimmer's position, where you had one arm up, one arm alongside, or both arms with the upper arms with the arms beside the body. And you can alternate the head to the left and the right every 2 hours. The length of time varied from 2 to 5 hours. So on average, about 3.5 hours at a time for proning. And the frequency was at minimum twice a day, but as frequently as the patient could tolerate. Monitoring is really important. As we turn this patient in a prone position, we want to make sure that their heart rate stays stable, their blood pressure, their respiratory rate and effort, their capnography, pulse oximetry, O2 settings, so all the things that we'd be monitoring if they were on, in an anterior position, but more closely so with the patients that are proning. And there will be some resources. Even if a patient is awake and alert and can self-prone, we want to make sure if we're in there assisting this patient that we have adequate PPE. Because of proning, depending on how the pressure of the feet are, you can develop foot drop. So a footboard may be very helpful. This may be painful for patients, so medicating prior to proning is important. If you're doing, if the patient has EKG leads, you need 2 sets, one on the front, one on the back, so that you can easily change the leads to the back. You may need a minimum of 2 staff, especially if they're weak or they need some assistance with pillows and support for this process. Suctioning, if they have lots of secretions. The one thing that was absolute across the literature, additional pillows, sheets, towels, blankets, anything that you could use to support the patient and to make sure that they have no excessive pressure. The foam dressings or the foam pads that you can use to support the bony prominences will help decrease the chance of pressure ulcers. And there are things like the turning support boards, like the Vollen Prone Positioner that was mentioned in multiple of the articles. Next slide, please. So other clinical considerations would be the complications, and we don't want any patient to have complications from this, but if we are diligent in how we do the procedure and how we are assessing and monitoring the patients, we can minimize these complications. So definitely pressure ulcers. If we do not take the time to carefully position the patient and check the patient's skin, there is a risk of pressure ulcers. Facial and orbital or ocular edema, again from having the face in that prone position. Accidental dislodgement or kinking of tubes. So as the patient is moving or we are helping the patient move, making sure that the tubes and lines are not kinked and they're clearly draining. Aspiration. These patients can have an excessive amount of secretions, so we need to make sure that they're positioned in a way that they're not going to aspirate. Eye injuries, corneal ulcerations, unilateral blindness, and retinal ischemia have been noted. So again, it's very important that positioning is key and that we're assessing the patient frequently. Nerve damage can occur from those bony promises or if we have the positioning not correct. So pressure neuropathies, hyperextension of shoulders, nerve injuries to the arms, wound dehiscence, if they've had surgery and we are rotating them, it's going to be very important that we're careful to assess the wound and make sure that there's no dehiscence. Cardiovascular instabilities or arrhythmias can occur, and then hemodynamic instability. So some of those contraindications can show up as complications. So we do need to monitor these patients very, very carefully. Next slide, please. So the key points that we really want to make sure that you understand is oxygenation has been a difficult issue to manage these COVID patients. Research supports proning changes and the natural mechanics of ventilating the lungs and improves the oxygenation in proning. The literature supports early proning. So as early as it's been identified that this patient is very sick, it's easily implemented, it's very cost effective, and it shows promise of improving the outcomes of these patients. Early proning does require staff, patient, and family education for them to understand why it's important for them to be lying in this position. Patients who are early proning must be monitored for changes in condition and potential complications, and definitely more research needs to be done around this early proning. Next slide, please. So as we think in terms of our evidence-based recommendation, definitely implement early proning as soon as potential COVID cases are identified. Train our clinicians, our patients, our families on early proning. How to prone, you'll need those human and supply resources for proper positioning. How often, at least twice a day or more often is tolerated. How long, a minimum of 30 minutes, on average 2 to 5 hours. But again, as long as we can have the patient tolerating it, as long as they can lay in that position, more benefit. Monitoring of the patient is critical. Assessing for potential complications is critical as well. Document the details of proning. The monitoring is the details. So it's going to be very important to know when they were proned, when they were turned back, any assessment in terms of pressure ulcer or pressure sores, redness, anything that you might note there. Engage your QI department right away to support tracking and trending the outcome data to see how proning is working with your patients, and engage your researchers to begin to conduct research on early proning. Next slide. So before we end, there is a email note or an address that we've posted in the Q&A to tell you if you are interested in getting our synthesis slides. The full synthesis tables, we'll be able to get those to you probably within the next few days. We are in the process of publication, and so until that publication goes through next week, we need to keep those synthesis tables with that publication. But if you would like them early and want to be able to use them in your practice right away, we're happy to share that information with you, and that will be posted again in the Q&A information. So just to conclude, let the evidence guide your journey. Engage quality improvement and engage research. And I love this quote. It's not necessarily the amount of time you spend at practice that counts. It's what you put into the practice. So thank you very much. We'll have questions at the end of the presentation.
Hi, everybody. Are you ready for the next presentation?
We are.
Yes, thank
Okay,
you.
great. So go ahead and advance the slide, please. Patients consistently report communication difficulty and the inability to speak during mechanical ventilation as highly distressing, frustrating, and frightening. The PPE masks that are required in caring for COVID patients are additional barriers, muffling your speech, and patients can't see your lips moving, so they might not even know that you're addressing them. Families aren't there to help. And so this is the perfect storm for an increased risk for miscommunication or missed communication. A classic example from our work of missed communication is the mechanically ventilated patient, or miscommunication. The mechanical ventilation patient who was asking for pants and consistently received pain medication. This occurred over a 2-week time period until the speech language pathologist was able to accurately interpret the patient's request. So you can see the danger there. Next slide, please. Evidence-based practice is all about challenging common clinical myths. And so we have a few here. There is no magic bullet or perfect communication tool for all patients, although everyone wants that. We all use multiple methods to communicate, and so do our patients. Your patients will need more than one method, and those methods may change during the course of their ICU treatment as their conditions change. And so the recommendation is to really match the tools and techniques to the patient's function. We'll say a little more about that as we go along. Nurses, no, we're back to, move the slide back, please. Okay. Patients have common needs and messages, but it's the unique and unanticipated topic or question that creates the greatest frustration and anxiety and agitation. Did my wife pay the mortgage? What's my status? Who has my dog? So while we might know the 5 things that they need to say, we don't really know what they need to say right now. without using appropriate techniques. In terms of lip reading, nurses tend to overestimate their lip reading accuracy. It's a very complex skill. Think of and prone to misinterpretation. Think of the YouTube videos that dub nonsense words into a politician's speech. Looks like that's what they're saying, but we know that can't be. So while family members at the bedside are helpful, family members report great difficulty and frustration in interpreting mechanically ventilated patients' messages. So they might not be really any better than the rest of us at this. More than half of mechanically ventilated ICU patients meet basic communication criteria. So the notion that patients who are mechanically ventilated can't use communication tools or just have to sort of tough it out until they're extubated is just really false. Next slide. We are members of the Patient Provider Communication Forum COVID-19 Task Force, which is a multidisciplinary network of speech-language pathologists and others. Our recommendations are gleaned from over 20 years of our research and the research of our colleagues and speech-language pathologists' practice experience. We do have an extensive reference list available upon request. Next slide. So our recommendations are around these 5 pillars. First, use a clinical decision guide. Secondly, your patient needs to understand what you are saying. So first, establishing comprehension support is key. Use simple communication tools, and we have those available for you to download and print out. Nurse training has been a component of our interventions to improve communication with mechanically ventilated patients. This training in how to communicate with communication impaired patients is really not part of usual nursing education. Nurses in our programs have significantly greater knowledge, comfort, and confidence in communication after training. So that training is available online and free for all of you. Demonstration videos are also available on our website, and so you can have like quick sort of demos of best practice in these techniques and the use of tools. And then last but certainly not least, we advise consulting the experts. Speech language pathologists may not be in the ICU right now while under COVID isolation, but they are available outside the rooms. They're available by video conferencing, and they really do stand ready to help. We have some examples on the patient provider communication website of case exemplars that are really fantastic. Next slide. This is the communication clinical decision pathway, and you see the way to access it with this code. Next slide. A closer look at the key assessment parameters of the decision pathway are cognition. Is the patient attentive or delirious? Can they use their hands to write or to point? Or are they too weak and lacking in coordination? And then to the lower left of, and this is just the top of the decision tree, all COVID-19 patients need comprehension support techniques to help them understand what you are saying. And Dr. Tate will lead you through some of those right now. Next slide, please.
Hi. So some of these are really easy things that you kind of don't think about, but something like so simple as getting the patient's attention by locking eyes. You do this anyway when you communicate with other people. It may be somewhat difficult for patients who are delirious because they have the attention problem. So the locking eyes tells them that you have a message to communicate. And if you look at this picture of Mary Beth and a patient, not real patient, she also uses some touch to gain attention. So that is important. Next slide, please. This is my favorite. If we look at, well, I guess I'm the only one on my screen that has a pair of glasses, but sensory deficits are ubiquitous, and our patients are, there you go, are older adults, and so they may have problems with vision and hearing. And then you add the PPE to that, now you're talking that it just creates a communication problem that's very, very difficult. If it's possible, keeping glasses and hearing aids at the bedside are really optimal. If there's a way that then they can be decontaminated, I don't know how you do that with a hearing aid. However, there are amplification methods that could be engaged through audiology that might be you know, a good short-term workaround. So an amplifier. Figure that people with hearing deficits also use, you know, lip reading to augment their hearing loss. Now with the PPE, you're talking about they can't rely on that either. So the idea of keeping glasses and hearing aids or an amplifier at the bedside are really important. Label the glasses as either distance or reading glasses. Hearing aid batteries in a normal time can be engaged through audiology. They can certainly provide those if you know, they're losing the juice. And then the other thing you could do is certainly print things up with large print. So you can write your message so that they can see it. Someone would have to do that with me because I wouldn't be able to see small print. Next slide, please. This is really important. A consistent yes, no. We think that, you know, we maybe have a workaround for patients who maybe have a bobblehead like this. They kind of don't do yes, no very well. And so that's the one we rely on, but people aren't really reliable yes, no head nodders. If they're not, you can certainly come up with a strategy for them, some eyes up or eyes scrunching their eyes for no, thumbs up or a thumb in their fist for no. The thing I want to be very clear about is what's written on the bottom of this slide. Post a communication care plan so that you don't have to reinvent the wheel every time you engage with a patient. So the next person on the next shift knows that you're going to be using this and this, and then every time you engage with a patient, you reiterate that. So imagine how confusing it is for an already sort of patient who's at risk for acute confusional state to have to answer yes, no questions using a different strategy for every person. So this is really important. You can post it on a piece of paper or your whiteboard or wherever, just so people know. And then a tag yes, no is a strategy that's based in speech language pathology. We've used it successfully in the past. When you're asking a yes, no questions, often patients just need to know, okay, so which answer am I supposed to have? Are you having pain? Yes or no? And so they understand they can kind of, hold on to that tag and then be able to answer and engage you in the correct answer. Next slide, please. I'm trying to advance the slides. Oh my goodness. Okay, you can use visual cues. So pointing or gesturing deliberately as you talk. So things that are culturally acceptable, things like, you have a headache, I'm gonna suction you, that kind of thing. So using those pointing or gesturing, or you could write some keywords or pictures. Certainly your oxygen is low, or we're gonna turn you on your stomach. You can write those messages out and then maybe they can read them. Next slide, please. This is an interesting strategy, almost like multiple choice questions. And I saw it used elegantly with a patient that we thought wasn't very communicative, but we learned so much about him and learned that he was afraid that he heard the nurses talking about his discharge and he was afraid to go home. And we wouldn't have known that if we hadn't used this written choice. So what kind of music would you like to listen to? And then you provide on a sheet of paper, maybe 4 choices for something. So this is really an excellent strategy for patients to communicate. Next slide, please. Writing tips. So I would suggest that if you're going to rely on writing, that you utilize a felt tip pen. Try to write with a ballpoint upside down, which most patients are not seated upright. They're usually writing in an upside down way. So those felt tip pens are usually really good. Often patients in this condition will have problems with grip strength or even their pincher, which you would use, to hold a pen. If you make that pen a little fatter, you can wrap tape around it. There are commercially available pen grips. I know you probably don't have them on your unit, but it's good enough to put something there so that they can hold it between their pointer finger and their thumb. Use a notebook. You can certainly get rid of it after the patient leaves the room if you're going to decontaminate it. A clipboard's a really good idea because it's hard to write on a surface that's not hard. So using just a plain old notebook is a little bit difficult. Often patients will have like a message dictionary. Certainly we've had patients that like flip through their pages to figure out what message they want to give you so they can use old messages. You can certainly use a dry erase board with markers if that's available to you. And there are electronic things that you could use. Now, this particular slide shows a laminated sort of piece of paper that you could use, and then you can wipe it off. I'm not so sure that in a pinch that you're going to be laminating boards for communication. I'm thinking that the first 2 things with paper and pen are going to be more acceptable, and really on the fly you're going to see it used more readily. Next slide, please. Certainly there are communication boards available. We have some that you could download in a pinch. This one on the left is in a sleeve. And certainly if patients have a message that's a little unique or you're having trouble understanding them, you can walk them through the lines of letters there to come up with the word that they're trying to express to you. We have some information about that, using that a little bit further on our website. And then there are commercially available hard boards like the Vititech board. There are other kinds of boards that are available, and there are electronic tablets that I think Mary Beth wants to talk about.
Yes, thanks. So these printable sheets also come in different languages. So there are language translations available on the website for you to print out. Just grab and go, put in a plastic sheet if you'd like. The electronic tablets, we've certainly seen that these are being used to connect COVID-19 patients to loved ones. There are also communication apps available to download onto electronic tablets. Voice output seems to be important and appreciated by patients. I've been involved in the iterative development and testing of the VitaTalk app. I don't have any interest or financial gain in it. Just know that I've worked in the development and testing, so have familiarity there. And there are others both offered by the Society for Critical Care Medicine, and other vendors. With both the electronic apps and the simple patient communication boards, you want to make sure that you confirm that that is the selection that the patient wanted to make. Is that what you want to say? So you just do always confirm and validate the patient's message. Next slide. These are the codes for accessing the website for the patient-provider communication website, with the tools available for download, as well as case exemplar tabs, and the additional resources tab has ways to access the electronic communication apps. The VitaTalk one is being offered free through May. So those downloads are available. And I think we're ready to answer questions. I'd like to acknowledge the Patient Provider Communication Forum. This is just a great group, and they've worked really hard on compiling these resources.
Okay, so this is Lynn. I'm back. Just want to thank everybody, Mary Beth and Judy, for their expertise and bringing this additional body of work to us to be able to get out into the community of people that are tuning into the Fold webinars. So much appreciated. Very, very informative, and just some seem like very simple things, but I think in the moment when you're overwhelmed with so many other things, that sometimes the simple things are the things that you miss the most. So we're going to try and cover questions related to both sets of presenters, and they've been coming in on the chat room, so we will see what we can get to folks. So Bindu, do you want to address? Bindu, can you address how people can access the recording and stuff like that?
Yes, I can definitely respond to those. In terms of the question and answers, please feel free to use the chat window and the Q&A pod to ask your questions. Some of our panelists will be reading them out aloud and letting the presenters take a turn to respond to those questions, especially those related to the content. And any related to the recording, I will post the website where you can access the recording and handouts, if any, directly through our website. So we'll post it in maybe tomorrow at the latest. We'll be posting the recording once we have a chance to edit it and then get all the handouts together. Take it away, panelists. Thank you.
So this is Lynn again. I wanted to just highlight something that one of our colleagues here posted in terms of the hearing aids. As a hearing aid wearer herself, she said they can be cleaned off with wipes that folks are using to clean other surfaces. It's just important not to get them too wet when you wipe them, and they cannot be immersed in a bucket of water. So, and then a comment about amplification devices depends on the type and extent of the hearing loss. That's why it's terrific to try to provide paper and pen to write if the patient is able, and not all hearing impaired patients can read lips. So some truly expert additional advice there from Lynn Brophy. So thanks, Lynn, for that. How about some of these proning questions? You guys want to take some of those on?
Sure. First of all, we've had several people ask again about the synthesis documents. The slides will be available as well as the documents. If you would like the documents before they're posted on our website, you just need to email us at all lowercase contact-fold, F-U-L-D, at osu.edu, and we'll be happy to make those available to you. And we will be eventually posting them on the website, but if you would like them now, all you have to do is do an email request to us. And I think that I've had several requests there. And then we had some other questions. I know that there was a couple of questions on the very low weight, so under 40 kilos, and the very tall, over 198 centimeters. From the articles, the big emphasis was on increase for the low weight people, was on increased pressure ulcers and potential nerve damage and positioning because of such a low body mass. And then for the very large, very tall patients, it was because they don't fit in the beds. And unless you have a special bed extender that can take care of very, very tall people, it's very difficult to properly position them in a prone position without getting complications like foot drop and nerve damage. So hopefully that answers your questions. Let's see.
Also, we'd like to thank George from Fresno State for your question. It said, could an incentive spirometer be used in conjunction with proning? I didn't notice as a contraindication. So George, thanks for the question. None of the literature discussed incentive spirometry anywhere. So it was not part of the, what was talked about within the literature. But I would encourage you to consult with your respiratory therapists and see what they have to say about that.
There were also some questions about pressure injuries related to proning and recommendations for preventing pressure injuries related to proning. And I know that Cindy did touch on this, so I just want to make it clear. This was a potential complication from proning. However, none of the articles that we looked at that actually performed awake proning had these complications happen. They did note that this was a potential complication. And for strategies such as foam dressings, pillows, blankets to help with turning and positioning could be utilized to prevent pressure.
And Laura, I think there were several comments about why the proning time frame was so much shorter in ventilated patients. Historically, the literature talks about 12 to 16 hours of proning. It's because they're sedated and they're in a position where we can manage them. When you're awake and alert, being able to get a patient to prone for 30 minutes may be a challenge. So multiple bouts of 30 minutes may be all you can get. Ideally, though, if you can get them in a longer period of time, even up to 5 hours is ideal. But it's the shorter amounts of time because they're awake and alert and they're wanting to move back and forth for the early proning.
And to Cindy's point, continuing to encourage them to stay in prone position or to return to prone position as much as possible is helpful. Colleen M says, would turning the head side to side be the best way to decrease eye injury with proning? Again, certainly turning your head from side to side, the literature spoke about how that, again, would change the pressure, the ocular pressure and such as well. Especially with awake patients, they're more able to adjust their body and feel some of the, some of the issues or the discomforts that can come along with it. So adjust as they need to. But yes, turning the head from side to side helps as well.
And turning, there was just a couple of articles that I saw with pregnancy. They were all with ventilated patients. But I was just on a webinar last week that talked about management of COVID patients that are pregnant. Side to side may be the best option for a gravid uterus. So it does definitely help. They have used proning positions with severe patients that have COVID, and they've used multiple pillows, and they've even started using inflated inner tubes that can go around the gravid uterus. So be creative, but make sure that you're monitoring and making sure that there's no pressure points or potential complications.
So for the proning group, did anybody address the whether or not there was anything in the literature about Trendelenburg position? Because I know that there's, I've heard this, I see it here, And I've heard that question from some other people, like head up, head down. Is, you know, was there anything in the literature about that as a do it or don't?
Everything I read was flat. I don't know if any of the other people, yeah, I didn't come across anything that was that addressed Trendelenburg.
Yeah.
And that would increase your ocular pressures as well.
Right. Ocular pressures and cranial pressures and things like that. So I did not see anything in the articles about Trendelenburg. And merely the mechanics, the natural change in the physiology or the way that the body is laying and the structures within it by turning on your belly just naturally helps to increase, you know, drainage and such as well. But we will continue to look for that.
Absolutely.
So again, I'm just watching the comments coming in here. So some other, go ahead.
There was a question for our communication group about the website again to access communication resources.
Yes, I'm writing that now. It's HTTPS. So some of what I'm seeing is eliminating the S, and it's go.osu.edu/speak. SPEACS. So that's where you can access both the training, video demonstrations, references, and this clinical decision pathway. So use the tabs on the top toolbar to access those.
So there, excuse me. So there is some back and forth about the positioning for the proning. So I think it sounds to me from what different people are saying is there are reasons pro and con. It wasn't in the literature to make a recommendation to do it or not, but it sounds like people are doing it and not doing it for different reasons. So I would encourage you to think about the things that, you know, a position change is going to impact and make that, you know, and use that as part, you know, based on your assessment of the patient, do they have this or that? And would this be a good idea? Because for some reasons, Trendelenburg is particularly a bad idea. And some reasons it might be a good idea, but I think that's based on a decision beyond what the actual evidence says. The evidence, from what I'm understanding, from what I've heard from you guys, is flat. That's what we can say. And beyond that is getting creative. So, and then the other thing I wanted to get back to the communication stuff. So we're going to get some stuff onto the website in collaboration with Mary Beth and some, you know, just some simple one-page resources like we've put out about all the other stuff we're doing. So we're working on those as we speak to get stuff that you can get right off the Fold website, and then we'll try to link to all the other stuff that Mary Beth is talking about relative to these other great websites, so that you can just come in and get whatever you need and find your way to all these amazing resources that are out there. And, you know, I think what Mary Beth and, you know, talking to her earlier a couple of weeks ago was like, there's just so much out there. And what we tried to do here, what Mary Beth and Judy tried to do is just get you, we're trying to do things that are just like grab and go. Like what are those key top things that if you can at least do these things, you know, they're the best start, but there is a wealth of information beyond in most of these presentations we've done. There's way more for you to get into when you can. And such is true for the communication stuff and this proning stuff, right? Mm-hmm. I mean, these synthesis tables are pretty deep and rich.
Yeah, if I could make a couple more comments, Lynn, the grab and go, the tips will also include additional ways to support comprehension of the patient. So we recommend really speak in short, distinct, clear messages, almost broadcaster speech, so that patients have time to understand and process, because, you know, they're a little foggy and can be delirious. Delirium is a real problem with these patients. So we want to really keep those phrasings short and to the point and not stack our questions. One question at a time, one message at a time.
All right, let me see if there's any other questions to try to address in our last couple of minutes.
Lynn, there's a question from Alex concerning, even if you have a low weight person, would it be a, the benefit risk of, yes, they're at risk for increased pressure ulcers or complications, but would the proning be a benefit that would outweigh the risk? And I would say you would have to do an assessment on the patient. I mean, some small people, they may be low weight, but they have good body mass. They may be a candidate for proning. So I think it's just, from the literature, it's clearly assessing and making sure that you're positioning the patient with the right amount of padding and the right amount of support so that they don't end up developing complications. So for that very tiny person or that very low weight person, I think you're going to have to assess on a case-by-case basis for that person. And there was one other question. I'm sorry, trying to capture all of these.
Hey, Cindy, there's one about anecdotal there was a comment saying anecdotal recommendation out of New York is creating proning teams to ensure quality and safety. And I would just like to address that one. Absolutely, having proning teams is critical, especially for mechanically ventilated patients. And that's where more often we saw that within the literature was with mechanically ventilated patients, because you've got ET tubes and lines and, invasive monitoring, things going all over the place that you got to keep track of. So in some places too, we've heard that teams from surgery are being deployed since they're not doing as many surgeries as before, and they're really pros at getting people into prone position. Some places are tapping on their surgical teams to come and help be part of those proning teams, or to be the proning teams with critical care and respiratory staff, there as well. But with early proning, remember, most of these people don't have tubes coming out of everywhere. And so again, important, the literature recommended a minimum of 2 people, but again, depending on the status of the patient and the lines that they have and things like that would kind of dictate how many people or tapping on those proning teams. So great point.
Yeah, and there was a couple of comments about, what is the minimum, or let me see if I can find, if you only, sorry, I lost it, it flipped up, but it was talking about, would they get a benefit even from a minimum amount of proning? There were studies that were done in, different, pediatric and neonatal populations, which have different physiology, as short as 30-minute periods. So I think any amount of proning would be beneficial. So if you've got a patient that you put them in prone and they turn right out after 30, 40 minutes, just say, okay, we're going to do that again, and just keep encouraging them for shorter periods of time. There was not discussion about proning versus sitting up in any of the studies I saw.
No, but in the Sun article, Sun 2020, which was the article out of China, one of the things that they did talk about was they doing an initial prone of 30 minutes to see how the patient tolerates it, and then go from there. The other thing too that we saw across multiple studies is that although the literature obviously showed positive outcomes from proning, that those outcomes weren't always immediate, and they weren't always dramatic, but that certainly they saw improvement in all kinds of, again, statistics or measures around respiratory oxygenation and such, they also felt like that was cumulative. So the more they proned, the better it was.
The other question I thought was really interesting, and I don't know whether you saw it in the literature or not, is proning something that people who are not that sick yet, who are still at home, is it something that proactively people might want to recommend for even just family members who are
It is
getting sicker and trying to avoid going to the hospital?
It absolutely is, Lynn. And in fact, in one of the articles, they actually provided a patient education piece that they were using in the ER with patients who would come into the ER and were being discharged to home. And it's done in both Spanish and English. But again, talking about early proning or self-proning and the advantages of that, and encouraging people to do that at home.
Right. Let's see.
Nancy Powell says our proning team goes around and teaches patients to self-prone. That's
Right.
amazing, Nancy. And again, although the literature doesn't support that it decreases mortality rates, there are a lot of other, the literature supports there are a lot of other benefits. And so it seems that maybe it buys time and helps improve things while the body is continuing to fight off the virus.
So I have, this is Lynn, I have one anecdotal piece to add to that. I have a dear friend who is out of the ICU, having survived a very intense COVID experience. And what he has shared with me is he believes, he feels that proning, his self-proning was absolutely critical. He could feel it make a difference. So not evidence-based, but one lived experience. So even, that's important. Like he felt like there was something he was able to do that was making a difference. And so he absolutely said, he could feel it making things move better, and he felt like it was really helping him. So I just add that as, another layer of the evidence that's emerging from people who are surviving and able to tell us their stories. So more to come on that, hopefully.
And as we're wrapping up, I just want to again emphasize the importance of bringing quality improvement people into this conversation and this work right now, so that we can start collecting data and metrics on the outcomes of early proning when you guys, engage in it. Make sure that you're documenting with detail, so that when it comes time to do retroactive chart reviews and such, there's good information in there to collect. And again, we know that at this point, the literature is still not robust around this. Although, again, it's cost effective, it's easy to implement, it's positioning. It's what we as clinicians get taught in our very basic fundamental courses, clinical courses. And so, again, grab and tap those researchers. This is where EVP, QI, and research come together beautifully to really, again, capture the data and make a difference in the long term. So we can't thank you guys enough for being here with us today and addressing, these important topics, because together we really can make a difference and build the body of evidence for those who come after us.
All right. Well, thank you, everybody. Appreciate your attendance. Appreciate all of you who did this hard work to bring this information forward in a way that we know is, best practice, and hopefully, sort of framed in ways that people who are under a lot of pressure to do the right thing have an easy and reliable way to find out what, the best practice is. So thank you to Mary Beth and her expert group that's working out there and bringing this, through the fold and out to more people, and to our full team of DNP students and EBP experts. Appreciate so much everybody putting their efforts together to do this work. And so we are here, we are continuing to look at topics that we are hearing from you are important. If there's something you need us to be looking at, get in touch with us, and we will put our full, put our efforts behind getting you, you folks, what you need to do the best you can to take care of these patients and these families and yourselves. And thank you all for being here.